This conference will now be recorded.
Okay, good evening and welcome to AnCan's virtual support group for low and intermediate risk prostate cancer for Monday, October 27th, 2025. And welcome to our first time visitors and hello to all of our regulars. I'm your moderator for this evening, Stuart Jordan, and I'm being assisted by Dr. John Antonucci. At AnCan, we have multiple prostate cancer groups for our attendees. In addition to tonight's group for low intermediate, we have groups that focus on active surveillance, high risk, recurrent, and advanced prostate cancer. We have a group for military, we have veterans, we have one for men under 60, and our newest group, just starting this month, is for gay and bi men. So we try and help you find the right place to be. You're always welcome in any or all of our sessions. Tonight's group, we address low and intermediate risk, and we're talking primarily to those who are planning for or have had treatment. We do not discuss recurrence in this group and instead invite those folks to join the high risk recurrent group. And would like to remind everybody that AnCan is a peer-to-peer support group, and please do not take what we share as medical advice. We're here to share our experience and answer your questions and hope that you will provide you with valuable information that we encourage you to discuss with your doctors. And before we begin this evening, we'd like to mention and thank our sponsors, Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, and Foundation Medicine. As well, we thank all of our supporting members, and if you would like to support AnCan, please visit our website, www.ancan.org. So with that said, we will go ahead and get started. And for the new folks, just to explain how we like to work, with all of you, we are going to take 15-20 minutes or so to allow you to introduce yourselves to us and share information. And the way we like to do this is we have a set of questions that we like to run through, because partially to make sure we get a full picture so that we can, as hopefully as intelligently as possible, learn from you, your story, and help share with you. So please bear with us as please bear with me as I go through this, and we will hopefully, so Mark Nicholson, you're up.
Yes,
And
I'm here.
You're great and welcome. And Mark, how old are you?
64. I turned 65 this weekend.
Oh, well, happy birthday, a few days early.
Thanks.
And where do you live? You're Houston. Okay. Are you right downtown or out in the suburbs?
Way out in the burbs. I'm technically not even in Houston.
Okay. I lived there briefly many years ago. So, Mark, are you a veteran?
No.
Okay. And how did you hear about AnCan?
My sister.
Okay.
She did some research and told me about it, and I watched a couple of videos already, so I'm aware of some of the questions, and hopefully I'm somewhat prepared, I hope.
Okay. And have you signed up with your email to receive reminders?
Yes.
Okay. Great. So, when were you first diagnosed, and how did that come about?
Diagnosed in August of this year, after a biopsy towards the end of the month, and PSA had been creeping up, 1.6 back in 2009, 2.1 in 2015, 3 in 2018, 4 in 2021. It's kind of gradually creeping up
Okay.
here. 5 in 2023, 4.8 in 2024, then 8 later in 2024. 7.68 actually, and then tested again in August, and it was 7.97. So the urologist said, let's do a biopsy, and I can run you through that real quick if you need that
Okay, yeah,
information.
we got the PSA stuff. So, before we get to the biopsy, based on your PSA history, at any point, did you have an MRI prior to your biopsy?
Not prior, afterwards.
Okay. And what did sort of out of order, we'll come back to the biopsy, but what did the MRI say?
Okay, the MRI showed everything. Let's see, very good news. Cancer is completely contained in prostate, no external cancer.
Okay. Did it identify any lesions or give you a PIRADS score?
Okay, what kind of score was that? I'm sorry.
PIRADS,
PIRADS.
P-I.
Okay, that's a 4.
Okay.
I don't know what that means, if that's good or
Okay.
horrible or.
PIRADS is the score. It goes from 1 to 5, 5 being the worst. And what PIRADS does is it's their prediction of the likelihood of cancer being present. And 3 is maybe it is, maybe it isn't. 4 is it's most likely there's cancer there, and 5 is flashing red lights, there's something serious. So
Okay.
at 4, it's all that 4 is saying is they're most likely they're seeing cancer on the MRI. Before we get too deep into your biopsy, do you have any other medical history that we should possibly know about that might have an impact on your treatment situation going forward?
I do not. Everything else is good. I'm not on any medications. So I am okay otherwise.
Okay. Okay, so let's talk about your biopsy. Was the biopsy done in your doctor's office, or was it done at a medical center?
It was done at the doctor's office.
Okay. Do you know if it was transrectal or
Yes,
transperineal?
transrectal, and it was ultrasound.
Okay. So not a fusion targeted biopsy.
Correct.
Okay.
And I've got some questions about that, but we can whenever get back to that.
Let's collect the rest of your biopsy stuff, and then we'll pause and talk through all this. What were the results of the biopsy?
Okay, he took 12 core samples. Out of the 12, 5 had cancer. Out of those 5, 3 had a Gleason score of 4+3. I'm sorry, 2 were 4+3, and 3 were 3+3.
2 or 4+3, and 3 or 3+3.
Correct.
Okay. On the 4+3s, do you have the percentage of 4?
Yes, 1 is 5%, 1 is 25%.
Okay, those numbers don't, those numbers don't correspond with 4 plus 3. Are you sure it's not 3 plus 4?
I wonder if it's 25% of the whole core that was Gleason 4, because it can't be 25% of the cancer.
Well, maybe didn't hear the question correctly, but I think it's, from the way I understand it, it was 25% of the core. Because I asked this question
Okay.
at the last appointment I had.
Okay. And the other one is, you were saying, was 5% of the core.
Correct.
Okay. Were there any other mentions of anything else, cribiform, perineal invasion, any other comments about the samples?
Yes. Let's see. Focal intraductal carcinoma is identified. No perineural invasion is identified.
So I'm sorry, the first one, intraductal, was identified or not?
Intraductal carcinoma is identified.
Okay.
And I don't know what that is, but
okay, we'll come back to that, but you said no cribiform.
no. How do you spell that?
CRIBRIFORM.
Okay, I do not see that. It's pretty
Okay.
small font here. I'm kind of magnifying glass going through
And
it.
I'm sorry, the other one was perineal.
Yeah, he
No
said
perineal.
no perineural invasion is identified. And it also said no tumor in the extraprostatic adipose tissue is identified.
Okay.
Adipose tissue, okay.
Okay. And have you had any sort of second opinion?
No, I'm waiting for my birthday to call MD Anderson, unless there's somebody else I should call. Because I live in Houston, I was going to take advantage of them, unless you guys can recommend somebody you think is better.
Okay.
And I was going to get a second opinion. And actually, I've contacted, on you guys' recommendation from watching YouTube, I've contacted Dr. Epstein. He and I've been back and forth a couple of times. So I'm working on getting the lab that did my biopsy, the read of my biopsy slides, to send the slides to him. So hopefully that's in motion.
That was going to be the recommendation if you hadn't done it. So that is for you, is going to be very important, because we want a second set of eyes on the slides to confirm or to reclassify the level of cancer that they're seeing, because that could make a significant difference on the treatment options that are appropriate for you. And then
Okay.
the last questions, and then we'll turn over to your questions. Was there any genetic testing, Decipher, Polaris, that was done on your cancer samples?
Okay, he said, and I'm just now seeing this, a Polaris molecular predictive test and germline analysis have been approved.
Okay.
So I guess they were approved. I don't know if the results are back or what's going on there.
Okay. You should check back with the office to see if you've got the Polaris score back. That's a prediction of the aggressiveness of the cancer that's determined by looking at the genetics of your specific cancer sample. So that too will be important to the doctors when it comes time to talk about what your opportunities are.
Okay,
So I guess my last question to you is, so your biopsy was in August, right?
correct.
You've been, I assume at this point you've been back and had further conversation with the doctor?
I had an MRI a couple of weeks later. It was on a 3T machine with and without contrast.
Okay,
And then we had the appointment after that.
okay. And what has the doctor told you?
Okay, other than go back up to my notes, he said cancer is completely and contained in the prostate. He was going to order a PET scan for me once Medicare kicks in. And he said that's the last test they can run to check off that box. I might get a second opinion from MD Anderson before I do that, or I don't know where we are here. And regarding the MRI, he said they would treat the entire prostate with radiation, and the whole prostate would be affected. It wouldn't damage the prostate, but the tissue would be changed. And I've got questions about that we can come back to. So,
Okay, so well, the idea of waiting till after your birthday to get to Medicare for the PSMA makes total sense. And given that your initial diagnosis is 4+3, it should get approved and should confirm whether if there was any cancer that has left the prostate, which would be important to know. So it's one more test to go through. It's not a big deal. I had one last week, so. But what are your questions,
my
Mark?
questions. Oh, okay, so back to that PET scan we were just talking about. He said it was a prostate specific scan. It would just do the prostate. Should we zoom out a little bit and see more than that, or?
Well, what a PSMA PET scan does is it will look at more than that. It pretty standard. It goes from the waist up, because what happens is they inject a radioactive agent into your bloodstream and they wait for it to circulate around, and the prostate cancer binds with the agent, and that's what emits the signal. So they look around for any place where the signal might be coming from. It could be the bones, it could be other organs. So they look at it, they look at everywhere to see if there's anything abnormal.
Okay.
It's a great test in the sense that it's so specific and it's relatively high success rate. It's like 75-80%. If it's there, it will see it.
Okay.
So, and you go, they inject it, you sit around for an hour or so until it moves its way around the body, and then you do PET scan, which is relatively quick and much less intense than an MRI if you're claustrophobic. And then they send you home and tell you to drink a lot of water.
Okay.
But given the initial diagnosis, it's appropriate for it to be there.
Okay.
For you to have that test.
All right. Listen to you guys talk. I can't remember I've listened to the last two meetings, or watched them actually. You guys stated that using ultrasound for the biopsy is not the preferred method. And I asked my urologist about that, if they use micro ultrasound or regular ultrasound, and he said it was regular. And then I went and looked at MD Anderson's webpage, and they flat out stated they just used ultrasound. And this is MD Anderson. So any
Right.
thoughts on that?
Standard of care at this point is MRI before biopsy, because
Okay.
MRI gives, the MRI sees most, it's fairly highly accurate in terms of identifying the potential location of cancer. It doesn't tell you whether there's cancer or not, but it tells the doctors where they are supposed to look. And then you take that MRI and you overlay that, and that way you go straight for the high probability locations so that you can try and make sure that you find it. The real challenge with the biopsy, otherwise, it's just totally blind, and it's hit or miss. They use a grid in terms of trying to cover all the areas, but it's sort of luck of the draw whether you hit it or not. Now, normally, if you had come to us and said, "Hi, my doctor gave me a biopsy. He's got it, and we got a result," we would say, you have an issue, because the MRI really needs to be in front of the biopsy to make sure you have a quality biopsy. In this case, and this is a question that you might want to take back to your doctor, is to confirm if the location of where he found the cancer in the biopsy matches where the MRI after the fact saw the PIRADS 4. Because
Okay.
if the answer is no, then that means there could be additional cancer that he didn't hit with his biopsy.
Okay, that was kind of, yeah. I was wondering about that. I was wondering, should I go back and get a targeted biopsy at this point? But I guess your question will lead into that.
The fact that you have an MRI, again, it's after the fact, which is sort of backwards, but it does give them something to compare the biopsy against to figure out if the area of concern is the area that they hit. So I would want to know the answer to that question before running back for another biopsy. And then the other thing is, you want to get the Dr. Epstein to look at your slides and give you that second opinion, and then you sort of have to collect the information and decide whether you're comfortable enough or whether you need more information before you make a treatment decision.
Okay,
I can make a comment maybe
Sure.
about
Please.
that second biopsy idea. Stuart is absolutely right, and it would be really nice to overlay the MRI and see whether that PIRADS 4 lesion was in the same spot as your 4+3 intraductal carcinoma. That would be interesting to see. But if you look at it this way, let's say you get another biopsy and they don't come out with anything more than is already known, then it will not change your treatment plan. Let's say you get another biopsy and they find something new inside the prostate, which is worse than what you've already got, like some Gleason grade 5. That's not going to really change your treatment plan either. So you're not an active surveillance candidate. You're going to be treated, and I think the treatment will be the same no matter what the second biopsy will show.
okay, that's good thoughts. Question on the treatment. My urologist mentioned, he said they would treat the entire prostate. And is that standard procedure? Is that normal and customary, or that's kind of a two-part question? And then the second, does this damage the prostate or change its function?
Oh,
In other words, I guess long-term effects.
David, you want to?
David, you're muted there.
Your story is a lot like mine. The trajectory of your PSA was almost dead on what mine was. And I also got a 4+3, and I got diagnosed just a year after joining Medicare. So I got a couple things to say about Medicare if you want to hear them too. But regarding your treatment, um, when you have a 4+3, assuming that's what you have, and maybe Dr. Epstein will change that and possibly even lower it or raise it or who knows what. But let's assume for right now it is a 4+3, which is, like I said, the same as I have. A 4+3 is a fairly serious cancer. It tends to behave more like a high risk cancer than like a low risk cancer. A 3+4 tends to behave more like a low risk cancer. 4+3 tends to go the other way. And knowing that, the first treatment, the primary treatment, was my best chance of really knocking out this cancer for good, I went fairly aggressive with it and underwent IMRT, which is beam radiation to the prostate and the pelvic lymph nodes. And on top of that, did an HDR brachy boost. And getting to your and the reason I like that approach is because the brachy really delivers a very hard punch to the cancer inside the prostate, and the beam kind of covers the surrounding nearby area in case there are any stray cancer cells. Now, you asked about, does it change the prostate or the function of the prostate? Yeah, definitely. Immediately after that treatment, for about 2 weeks, peeing was very uncomfortable because when they radiate the prostate, they radiate the urethra within the prostate. And it took about on the 3rd week, my urinary symptoms, and those were the only symptoms I had were urinary ones, they improved by about 80%. It's literally overnight. It's just like, wow, so much better. And by 2 months, I had no symptoms. I'm now 3 months post treatment, have no symptoms. And you're lucky because at MD Anderson, there is a guy there named Stephen Frank, who's one of the best radiation oncologists in the country. He's in the forefront of a type of brachytherapy called MRI guided brachytherapy. This gives the MRI portion of it, very similar to a biopsy, gives them much better imagery so they can direct that radiation to where it really needs to go to keep it from hitting healthy tissue. There are not that many doctors who do MRI guided brachytherapy. Stephen Frank is absolutely top notch. He's not the one who did mine. I also had MRI brachytherapy done by a doctor in Colorado. But just geographically, you're in a good place. But yes, it will affect your urination for a while. And over time, your prostate just won't function the way it used to because it's getting hit by all that radiation.
Mark, we don't
Yes.
want to get too ahead of ourselves here in terms of, the next thing that really you have to do is make sure you've got a solid diagnosis. And I don't want to get too deep into the treatment options before we're settled because there's still some room for things could move around and things may or may not totally be appropriate for you. But to answer the first part of your question, the standard treatment for most treatment, and especially if your level is diagnosed correctly, is to treat the entire prostate. There is a thing called focal therapy that only does a portion, but it's fairly limited as to who's a good candidate for that. And in many cases, or probably most cases, 4+3, it's not advised to do a partial focal treatment.
Okay.
Do you have
The only other
other
thing-
questions? Sure, go ahead.
I'm sorry. The only other thing I wanted to ask about, and this goes back to probably I'm putting the cart before the horse here, but Houston does have, MD Anderson, they do have a proton therapy machine, and I read some about that. I might ask them about that, but it, depends on what Dr. Epstein comes back with. And I'm just kind of casting a wide net right now, trying to get as much information as I can, because knowledge is power. So
Don't get hung up on the technology of the treatments. You can really end up chasing your tail on that, because everybody's got their own, has got their own bias and different opinions on stuff. And you really want to focus first on getting a good diagnosis, and then finding a good doctor that you trust to help guide you through the process. And then the treatment options and the choices and decisions that you'll make will become a lot simpler. So just as a peace of mind and to make life a little easier, don't go crazy. Don't go crazy on the chasing down all the different types of treatment at this point. You've got enough to deal with without having to try and get into all that.
okay, thank you.
Okay, David. David has his hand up, and then we'll move on.
Just one quick one, Mark. The PIRADS 4, it probably just identified one lesion. You could confirm that with your MRI. It will also tell you the size of the lesion and the location. So with that information, you can go back to your urologist and ask that question that was previously suggested. Did you hit the location where that lesion is? But it should be identified in your MRI report, the location and size.
Yeah, they've got some measurements on here for a nodule. So I could ask about that, but there's only one set of measurements on here, and then they did mention something else. But looking at my little graph of the grid they ran, there are 3 different nodes or 3 different cancer areas on here. Like you guys said, what if they missed some things in here? Because the urologist did say it was kind of like a archipelago island chain, and that's why they treat the whole prostate.
So again, John's point is really important. The fact that they have found cancer, and they found enough of it to be of concern to most likely require treatment. Once you get a second opinion on your slides, you probably then know enough about what you need to do, include that whether or not there's other stuff there that they didn't find really probably won't change what needs to happen. So
Okay.
I would, it's important. I think it's important to know whether or not what they found is what the MRI saw, just to give you some sense of what's going on. But beyond that, we really just want to know whether you really have 4+3, or whether it's 3+4, or so. I encourage you to follow through with Dr. Epstein. Get on the phone with him after he's seen your slides. He'll be real good about talking you through what he sees, and then come back and tell us what you got. And at that point, we can help guide you towards the right place, the right doctors, to get you the best care.
Great. Thank you very much.
Great. Well, good luck to you. Craig, I saw your note. If you're still here, I understand, and we'll move on. So, Greg Burns,
Yes.
you're next.
Okay. Thank you, gents.
How old are you?
I'm 68.
Okay. Same age as I am. And where do you live?
California,
Northern or southern?
the Bay Area.
Okay. Good place to be if you need to be treated.
Yes.
Are you a veteran?
No.
No. Okay. And how did you hear about AnCan? Oh, I think you told us.
A friend, somebody who had cancer, and then who introduced me to Rick, and the rest is history.
Okay. And do we have your, I think we have your email
Yes.
to get
Yes.
reminders?
Yes. I
Okay.
get reminders. Yeah.
Okay. When were you diagnosed?
June of 2023.
And how did that come about?
PSA went up to 5.1, I think it was. And then that's when the ball started rolling downhill.
Got it. Were you in California at that point?
Yeah.
Okay. So were your initial treatment at a community practice hospital?
Yeah, community cowboy. Honestly, I don't want to talk about, but I'm at Stanford now. But the first guy was somebody I'd rather not refer to anymore. He did let's bend you over my knee and we'll do a transrectal. Before you know what's going on, it's one of those things you don't. I didn't have access to AnCan before I raised that flag, and so anyway, it is what.
So, okay, so you had PSA going up, and then did you have an MRI?
Yeah, I've had two or three MRIs now, and those are all positive. PIRADS 4. I definitely have cancer. I've had 3 biopsies. Is it 3? Yeah, no, 2. Yeah, 3 biopsies. 1 transrectal and 2 transperineal. The most recently was in June of this year, and that found it had been moving. I had 3+3 originally, and then the second biopsy, I ended up with a little bit of 3+4. Less than 5% in 2 or 3 areas. And as of June, I have 4 areas with Gleason 3+4. 2 of them, or 3, I'm sorry, 3 of them are 3+4, and 2 of them are 5% or less, and 1 of them is less than 10%. And I've had both of those transperineal biopsies, second opinion by John Hopkins, but done. The initial stuff was at Stanford.
Okay.
No cribiform. I do have what's it called? Perineal invasion. Just a second. Is that what it's called?
Yes.
Yeah.
Yes.
What is that? To be honest, I don't know what it is.
John, can you help me out with that?
Perineural invasion, there's a network of nerves, and peri means near. So it means that the cancer has some invasive properties. Now, apparently, it hasn't invaded through the capsule or into the bladder neck or into the rectum or anything like that, because that would have showed up. But it does give an indication that it has somewhat of an invasive nature to it.
Okay. My Decipher score is 0.21, and I had a PET scan 2 weeks ago. I was listening to the fellow earlier, and yeah, exactly like you said, you spend about an hour just thinking about your toes, and then you go in, and but it's fairly painless, and fortunately it came back with no the reason I got it was because the MRI I had in actually my MRI was February, my biopsy was June. The MRI said, you know, 2 double negatives, possible maybe outside the prostate. And that was enough to scare me sideways. And after pushing and pushing, I finally got a PET scan and have thankfully found last week that it's negative. So that's the good news.
Okay. Now, so you've had the decipher, you've got the results. What is your doctor telling you?
Well, he said, as I kind of concurred, I think it's time to do something. And I've had a urologist at Stanford say that, and I've seen 2 radial oncologists, one at Stanford and another one at UCSF, and both of them are encouraging treatment.
What type of treatment?
We're talking SBRT. The one at Stanford, the reason I went there is because they have the MRI LINAC, MRI Radian,
Yep.
yeah. Whereas UCSF has the traditional. UCSF is Mac Roach, and Stanford is Dr. Mark Boyansky. So I'm kind of my curiosity, not curiosity, but my real question is, you know, maybe for folks, and if I don't want to jump the gun on if you have more questions for me, but I have a couple for you guys if I could share those.
No, we've covered most of the stuff we'd like to know from you. So what are your questions?
Yeah, I think I have 3. A gentleman earlier said his experiences with Medicare. That'd be a curiosity because so far it's so good. But you know, I know things can change. Secondly, is there really a difference between MRI LINAC and regular SBRT? And number 3 is Prostox. Is that something that people have used and found to be helpful to see if you will have urinary issues? And you've already answered my 4th question, so that would be it from Lake Wobegon.
Okay. Prostox. Prostox test looks to predict the minority of the population that they predict to be at high risk for long-term side effects from having radiation. If you have the opportunity to do it and are considering radiation therapy, you should definitely do that test.
Is it covered by Medicare?
I do not believe so. Mine was not.
Okay.
It's relatively inexpensive. You don't need the fancy multi-test. You just need the simple test.
Okay.
And it comes back with a very straightforward answer as to whether or not they're predicting risk.
Okay.
So
I literally have it. It's in the mail. The box is in the UPS is dropping it off day after tomorrow. Can I indicate, I don't know what Dr. Roach has indicated if he wants the simple or the complex, but can I register? I want just the simple or the complex.
If they've already ordered it and sending it to you, just do.
Okay.
I'm not gonna pretend to know more than Mac Roach. So whatever he wants you to have, I think you're in great hands. Jim Stewart, you have your hand up.
I did. I just wanted to say I've been on Medicare for my treatment, and they've been fantastic. They've covered everything. They've covered all my genetic testing. They covered. I went to UCSF for surgery. They covered all those costs 100%. They covered my PSMA PET scan 100%. So my experience with Medicare has been very, very good. The only thing they were hesitant to cover was I had an appointment at the hereditary cancer clinic, UCSF, because I've got the BRCA genetic variant, and that was something they didn't cover. But everything else, they've just been great, covering everything 100%.
Thank you. That's encouraging.
David?
Yes, my reference earlier to Medicare was actually probably going to be more helpful to Mark since he's just now about to join it. I was just going to say, like Jim Stewart, I have original Medicare and they cover everything. It's great. So I was just wanting to, during that 6-month enrollment period, if you've got a choice between regular Medicare and Medicare Advantage, and if you can afford the regular Medicare, that's definitely the one I would choose again, because you have much more freedom to decide what doctor and what institution you want to go to.
Tim?
Oh yeah, I wanted to say I forgot to mention that I do have a Medigap policy as well. I don't remember if I said that or not, but yeah, that they between those two they covered pretty much everything.
Jim, could I ask you which Medigap policy you have?
It's a Mutual of Omaha.
But I mean, is it G or N or what?
I think it's G.
Okay.
But I'm not absolutely certain that it's it still makes me dizzy to think about all that Medicare stuff. But yeah, I believe it's G, but I'm not absolutely certain.
Dr. John?
I think if I were in your place, Greg, I would also go for radiation, but it's not completely out of the realm of possibility to consider active surveillance for a person like you. You got a low Decipher score, you got less than 10% Gleason grade 4 cancer. You might be on the high end of people that could do active surveillance. Let's say your Prostox score came back and predicted a lot of trouble from radiation.
Okay.
I don't know. It's not impossible, I don't think.
Thank you. I believe
One of the go ahead, Greg.
Yeah, I'm in the your out says I'm in the gray area now, and I think you've articulated that as well. So, yeah.
There was a hand. Mark, West Virginia.
Well, I just wanted to say that I rode that active surveillance train for almost 10 years. So the medicine changes so much, just every year. I mean, just from my treatment to now, how much radiation and all that has changed. So I just say I chose active surveillance and I rode that train as long as I could. And it wasn't until numbers changed and the actual prostate changed before I started thinking about treatment. But the one thing I want everybody to know, when you decide to do that treatment, you're deciding right now for the information you have in front of you for right now. But once you make that decision, you get your treatment, things are going to change in the future. But don't be disappointed in the future because you're making your decision on right now, what's good for you right now, and the information you have right now. And so once I did it, I don't look back. I don't regret it. But let me tell you, I rode active surveillance for a very, very long time, and I don't regret it.
Thank you, Mark. Paul, you have a comment?
Yes, can you guys hear me?
Yep.
Yeah.
Okay. Just want to add a little thing regarding the Prostox test. So that's specifically give you the risk for SBRT, which is the shorter 5-day or less treatment versus the longer term treatment. For example, the 28, 40 plus day. That's the test. That's the function of the test. Tell you which one you higher risk for effects. Comparing those two treatment, a quick 5-day higher dose or the longer lower dose treatment.
Okay.
Greg, I just wanted to comment because I was in a similar place as you were a year and a half ago, and I was on that border between treat or surveillance. And one of the things I would recommend you to do is when talking to your doctors, Mac Roach is a fine doctor, and I would ask him what his take is on looking at your stuff as to whether or not he thinks you're a good surveillance candidate or not, because the really good doctors, they don't want to treat you if they don't have to. And they will give you a decent assessment as to why they think treatment is in order, or why, or what their assessment is on surveillance. My own case was a little bit different than yours in that my Decipher test was much higher. And as a result, most of the doctors, when I asked them about that question, treat or watch, they almost all recommended treatment because the Decipher to them was the deciding factor. Yours is on the other side. You got a little bit more in terms of number of cores. So I would be aggressive in terms of asking those doctors where they sense in there, because you've got a great surveillance program at UCSF. If in fact that's an option.
Right. I think my Decipher is low, but I think Roach, what he said was that things are moving up for you, and so he's recommending to do something. So again, and I'm kind of leaning towards that way. I'm not 100% sure. It's heartening to hear you guys. I was thinking of doing it in January or February. So I'm guessing I have, it's not a rush job to do. I don't have to rush into it. But again, I'm still kind of conflicted between the MRI Meridian and the and going with Roach with the 4 or 5, the traditional, I guess it's traditional SBRT. And it just as a final, not a final note, but we're talking about, riding that active surveillance train. I know that when I first got diagnosed and my hair was on fire and I was like, bouncing off the walls before I got to sit in on AnCan and learn what's going on, and I think at the time, I'm grateful I hung out, because I had no idea about MRI Meridian, guided or anything. And so, if I'd done anything then, it probably would have been the same. So now I'm kind of thinking that maybe I got lucky to had a 2.5-year ride to find out about and possibly have this Meridian MRI. So again, I'm curious if people have a take one way or the other about if it really is a safer option, and what are the collateral damage of the Meridian.
Okay, I can tell you firsthand. I had MRI Linac for part of my treatment last year. Mine was at Memorial Sloan Kettering in New York. And all of the research shows that it is as good or better than any of the other options in terms of tight margins and, protecting against things happening during the treatment, because it's taking a live picture.
Right.
I forget how many times per second, and if anything moves, it shuts down. And so I'm sort of biased in the sense that, I had the opportunity to have it and it worked out well for me. By the same token, when you got a doctor as good as Mac Roach, I've heard him speak, and you ask him about the other machine, and he said, that's nice. I'm perfectly comfortable and could do a great job with SBRT, and I believe 100% in the fact that he can.
Yeah.
So I sort of always come back to, when I was doing my research, I came across a couple of comments that were made that focus on the doctor, not on the machinery.
Right.
That it's the guy who's running the machine that you really care about. And if you've got a good one and you're comfortable with them, you trust the fact that he's made a decision based on what he thinks works and that he can deliver good results on.
Yeah. Well, the one I'm talking to is the head of the department. And in fact, Mac Roach wrote his recommendation letter. He said he has nothing bad to say about him. So I think I'm in good hands either way. It's one of those things when you have, good option. Good options are good to have. So, but I'm at that. That's my, inflection point now is deciding, which way to go with the machine, with the LINAC or with the regular. Yeah. But you're right. I've also heard that's what Rick would say as well. Don't go with the machine. Go with the person. Driving. Yeah.
Paul, comments? Paul, you're on mute.
No, I do not have any. I don't have not any more comment.
Okay. David?
I was just going to ask you a question, Stuart. When with MR Linac, do they do a rectal spacer, or can that be left out if you go with an MR Linac?
My doctor in New York addresses the spacer on a case-by-case basis. There are he sort of looks at it, and if he doesn't think it's necessary, he tells you that. And I know other people that he's treated where he's done it. So, it's not all or nothing. It has to do with, the location of the cancer. It has to do with other potential risks. One of the people that he did it for had a history of bowel issues. So he was trying to be extra careful. So that would be, Greg, that would be one other question that you want to make sure you're asking your doctors.
Yeah, neither one of them are using it. So I think that's, I guess I don't have that option. I actually remembered something I wanted to say earlier, and you were asking, you're talking about possible candidacy for SBR, for active surveillance. I think one of the things that tipped my hand, if you will, is and I don't know if this matters or not, and I can't seem to get a straight answer. The location of my lesion, which has gone from 1.2 to 1.4 cm. Sorry, I left that out over the last year. But I have a small prostate, about 40. It's not 40 cc. So, but anyway, the location of my was it posterior, mid, and I was told it's very close to the edge. And I actually managed to get a second opinion on my MRI reading from February this year. And I got a second opinion from NIH. And that also came back saying, it's very close to the edge. And I don't know if that makes a difference if it's close to the edge with the possibility of it going beyond the prostate, which is, of course, something all of us are trying to avoid. And that's, I think, the reason that's kind of forced my hand is, I don't know if this is the case, but if your lesion is somewhere in the fat of the land of your prostate and you have a bunch of, you have a demilitarized zone around it, you don't worry so much. But if I'm close to the edge, is that a damning, position to be in? So that's my question.
So can you hear me, guys? This is Rick. I'm driving home from the airport. And I've been listening along, Greg, and I figured it was you. And Greg and I have talked. The one thing where I differ a little bit with Stuart, because I know Mac, is I don't think you'll get a fair assessment of whether Greg is a good candidate at this time for active surveillance. Mac's going to want to radiate. That's Mac. In a close situation, what I've suggested is to have an appointment with Peter Carroll, because I think Peter Carroll will give Greg a very fair assessment as to whether to radiate. From what I know, the location of the tumor being so close to the edge right now, which is sort of the issue that's pushed Greg into action, is a factor. And the sort of person who's going to know how big a factor it is going to be a Peter Carroll. So if as I said to Greg, it may just be time. And we've been riding this train for quite a long time, and it may just be time. But if Greg really wants to try and go a little longer for his active surveillance, the best person I can think of to tell him whether he should or he shouldn't is going to be Peter. So that's other than that, I agree with everything that was said.
Thank you, Rick.
Greg, any other questions?
No, I believe that's it. But yeah, very helpful. Thank you, guys. So just to may I ask you what have been your symptoms after the Meridian Line Act?
Minimal. There was they prophylactically put you on Flomax for at least 3 months.
Yeah.
And I had a little bit of urinary issues in the first few weeks. Afterwards, it cleared up very quickly, and have had no other issues.
And may I ask about erectile dysfunction?
No real impact. I'm in a clinical trial that was a combination of both focal IRE plus Linac. And so if any more of my side effects were a result of the IRE treatment than they were from the radiation.
Okay.
But keep in mind, and I was in a session in New York, and everybody who has treatment is going to have some impact on erectile function. The research really supports that. So, it may not be much, but they're kidding you if they say there's none.
Right. Okay.
Well,
David had his hand up for a while and just took it down.
Sorry.
I don't know if he has a comment or.
I want to get on to, we have one more person to get to, but.
Of course, yeah.
David?
I was just going to say, if you're thinking about doing radiation, they will, and you've got a 4+3 for sure.
3 plus 4. 3 plus 4.
You have a 3+4. Okay, never mind.
Okay, well, Mark, definitely come back and tell us, or excuse me, Greg, definitely come back and tell us what happened, and we'll help you in the next step.
Great. Can I ask you one last question about the Prostox?
Sure.
Yeah. So is there any time, like between the time they send it to me, the time I have to use it and get it back to them? Is there a sell-by date on it, or it has to be immediate, or is it urgent? Do you know?
I don't know. I don't remember it being that urgent.
Okay.
It's just it's a simple swab test and it goes back.
Okay.
Now, since you're staring at potential radiation as an option, I'd go ahead and do it.
Yeah. No, I'm going to. Yeah.
Okay.
Thank you very much.
Thank you.
All of you gents. Thank you.
Great. Mark Erickson, you're up.
Hello.
Okay. Mark, how old are you?
So I'm 74
Okay. And where do you live?
in Boston.
Ah, near me. Okay. Are you a veteran?
Nope.
Okay. And how did you hear about AnCan?
I have a friend who's been going through this process for a while that recommended it.
Okay. Love to hear referrals. And do we have your email? Have you given us your email so that we can send you reminders?
No, but I've got it on my calendar, so I'm good.
Okay.
But
If you want
I'll
to
add my email.
Okay, if you want to post in the message box to either myself or to John, we can also help take care of it for you.
Okay.
The thing is that the reminders are a very good newsletter as well. There's a lot of good information. They're not just a reminder. They're kind of like a newsletter.
Great.
So Mark, tell us about your diagnosis. When were you first diagnosed and how did that come about?
Last May, I had some blood when I ejaculated, and then it took about a month and a half to get an MRI, and which came back with 2 lesions that were 4s, and then had a biopsy.
Okay, could I just stop you for a second before we
Sure.
get into the biopsy? Your PSA, what's your PSA?
Is 5.3, I think.
Has it always been in that range or did it go up?
It was lower, and I don't know the answer to that right now.
Okay, but you're currently at 5.3.
Right. The last time it was checked was in June.
Okay. And what prompted the MRI was the blood?
Yep.
Okay. And so you said you have 2 PIRADS 4s.
Yes.
Okay. So what happened after that? Oh, actually, let me just, because it's also my list here, just before we get into going into the biopsies, is there any other medical history or conditions that we should know about that might impact how your treatment might go?
Yep, I have BPH, my very enlarged prostate, and right now I'm on Flomax, finasteride, and tamsulosin.
All right, got the full house. Okay.
Yep.
Okay. So tell us about the biopsy.
The biopsy came back with, it was targeted, it was 18 points. There were, let's see, 1, 2, 3, 4, 3 plus 4s, 40%, 30%, 30%, and 60%. And then 1 4 plus 3 at 60%.
Okay. Was it a transperineal or transrectal?
Transrectal.
Okay. Was it fusion?
Yes.
Okay. And so I'm sorry. So it was 4 3 plus 4s and 1 4 plus 3.
Right.
Okay.
Then the 4 plus 3 was 60%.
60%. Okay.
Yeah.
Are all of them on the same side or are they on both sides?
Let's see how fast I can find that. Oh, in terms of the biopsy, left, 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 left. They're all on the left side, one side.
All on the left side. Okay.
Yeah, and then it does say note perineal invasion is identified in this case.
Okay, that's good. No mention of cribriform or interductal?
Nope.
Okay. Where I forgot to ask, where was your biopsy done? Was it done in a local practice or a medical facility?
Medical facility, urology clinic at Beth Israel.
Okay. So Beth Israel did the reading of the biopsy?
Yes.
Okay. Have you had a second opinion on your slides?
I have not done that. I did talk to the I met with an oncologist, radiologist, and a surgeon together, or one at a time. And I asked the surgeon about a second opinion. He said, you know, feel free to get one if you want. He said the fact that it came back at 60% kind of led him to believe that it was probably not necessary. He didn't say don't do it, but he said to him it looked pretty clear. And I would love to get people's opinion about that.
The statistics show that when you get a second set of eyes outside of the practice that did the initial thing, you've got up to a 30+% chance of it being regraded either up or down.
Okay.
Because keep in mind, this is, you know, this is somebody's eyeballs looking at a slide and seeing, yeah, and say, well, gosh, that sort of looks like this, or that sort of looks like that. Since you're at Beth Israel, my guess is you have a better than average set of eyes looking at the slides. But I would still, AnCan would tell you, you always want a Dr. Epstein or a Dr. Ming Xiao looking at those slides, because they've got the best experience and best set of eyes in the world. And they could see something different than your guys. And I can tell you personally, because I had second and actually ended up with a third opinion on my slides, and they did get changed. And my brother, he also had, he had Dr. Ming Xiao look at his slides, and unfortunately he got upgraded from 3+3 to 3+4. So I would still think that it's in your best interest to get somebody else to look at those slides.
Okay.
So you did they do a decipher test or one of the other genetic tests?
They did not.
Okay. Would have imagined that they would have, but yeah, again, the benefit of one of those tests is to predict the aggressiveness of the cancer. And when you're in the 3+4, 4+3 range, you're sort of sitting in the middle there with more options, and they sort of can use that as a piece of information to help guide which way to go with treatment. And and it could have, if in fact your 4+3 is confirmed, you're now in, a less desirable intermediate. And one of the serious questions for treatment will be whether or not ADT hormone is in addition to potentially radiation.
Right.
And a decipher test could help influence the doctors to decide as to whether or not that's necessary.
Okay.
So that is something that could help guide the decision. What did, since you talked to all these different doctors, what were their recommendations to you?
Actually all three of them ended up recommending surgery. Even the radiologist, I mean, he gave his spiel for radiation. And then he just said, because I had the other urinary issues that would probably likely be aggravated, I said, what would you do if you were in my shoes? And he said, I would opt for the surgery, not for the radiation.
Interesting. How good in general is your health?
Good.
because normally 74 recommending surgery for a 74-year-old is could be stretching it a little bit.
Okay.
So it's obviously every person is different, but there's obviously the older you are, the more risks that are involved with surgery, and the quality of and the length of the recovery.
Right.
So, but I'm not a doctor, and the fact that all of them there sort of pointed in that direction, I would strongly recommend that you find you go to a second institution and get a second opinion, especially focused on, how much they think the BPH and enlarged prostate changes the treatment option before I go
Okay.
rushing into surgery. John, do you have thoughts on that?
Yeah, we don't really like to see a person whisked into surgery unless it's clearly indicated. So I would definitely get myself another opinion about that before proceeding. So the surgeon recommended. You said you saw an oncologist, right?
Yes,
And the oncologist recommended surgery?
he did as well.
And this was a special prostate cancer genitourinary oncologist or a general oncologist?
He's the director of urinary oncology at Beth Israel.
So it was a GU oncologist. And the radiation therapist also?
Yes. Well, he's a straight radiation oncologist.
But he still said, I'd rather have you go to surgery before thinking about radiation.
Yeah, I was a little surprised because it seemed like he was, he was making the case for radiation. And then he, when I asked him, he said, yep, if I were you, if I were in your shoes, I would go for the operation.
Geez, that's 3 out of 3. Stuart and I are both surprised. And, I hate to have you. Wait, I got to mute somebody here.
I got it.
Oh, okay.
Henry, can you keep that on mute, please?
I think it's Mark's phone coming back at us or something. Mark, I'm going to just mute you. No, you got it?
It was Henry. You're good.
Henry, okay. So, yeah, I am surprised that there's such a universal recommendation for a 74-year-old guy to go in for surgery. I hate to have you see yet another person for an opinion, but I also kind of hate to have you go to surgery. Do you think that they're worried about doing radiation therapy because of your history of urinary problems, and that's what the issue is?
I think that's part of it. Yeah. Yeah.
So maybe they're all bending over backwards to not radiate your bladder because of the problems that you already have.
I think they were also concerned about the effects on the urethra.
Yeah.
Just from the radiation itself. Then at one point they mentioned some kind of, and I don't have this written in front of me, some kind of basically it sounded like a roto-rooter procedure that they were saying I might need if I went with the radiation.
Oh, because they're afraid that your urethra and your prostate will swell up and you'll have bladder, you'll have obstruction of your urine.
Right. I think that's it.
And you are, well, you don't have any of these genetic tests that Stuart was talking about, but you, other than that, seem to be at a risk level where sitting around and waiting is not gonna cut it.
Yeah.
Were any of these docs at Dana-Farber?
No. One of the guys, I don't know if you know him or not, is Peter Chang. I think he's the director of the, so actually it's not on his card here. He's the director of robotic surgery.
Mm-hmm.
But yeah.
Paul has his hand up. And then I think Henry might also have a comment. Paul?
No, I don't know what's going on. I don't have my hands up. Sorry.
Okay, not a problem. Henry, did you want to make a comment?
I think he's gone. Oh, no, there he is.
It's there.
I spoke to a radiation oncologist and a surgeon, and they both said it was to my best interest to have surgery also.
Mm-hmm.
So sometimes it's a necessary thing, I guess, depending on your particular situation.
What was your age when this was going on?
This was 2 years ago, so I was 62.
Okay. So, Mark, you know, part of this comes down to what your personal thoughts and preference. You know, if you're having, you know, I would sort of look at it if you're questioning whether or not you want to have the surgery, I would probably try and go find a good independent radiologist to get a second opinion as to what they think about the appropriateness of radiation treatment.
Radiation oncologist.
Yeah, and I'd be aiming for one of the top centers of excellence and finding the very, very best radiation oncologist with experience as possible to give you their opinion.
Rick may know an excellent radiation oncologist at Dana-Farber, which is right near where Mark lives. Maybe we could check with Rick and then get back to Mark.
Yeah, no, we definitely see that. Or otherwise, if you're up for any sort of travel, we could point you to New York and get you in to see someone at either MSK or NYU to get that opinion.
And then if even that person recommends surgery, I guess you're stuck.
Okay. Yeah, if you have suggestions as far as people, that would be helpful.
Definitely. If you would shoot your email address.
I put it in my profile there. Is that good enough, or?
I don't know, John, can you see it? I can't. If you throw it in the message chat, the message box.
Sure.
It's not in the chat right now.
Yeah.
Yeah, maybe if you could put it in the chat, and Stuart or I can get back to you.
Okay.
Because our boss really knows everybody, and he probably will know.
You know, if there's somebody in Boston that Rick knows, otherwise I can help point you to the doctors in New York that would be the other places where I would go to get an opinion. Other questions, Mark, that we can do for you this evening?
I don't think so at this point.
Okay, well, we'll get you some information to follow up. Just give us your email address there, and there it is. And we will come back and tell us keep us informed through your journey so we can help you.
Oh, isn't Anthony D'Amico a radiation oncologist at Dana-Farber? I'll check with Rick and get back to you. I think D'Amico is there, and they have lots of radiation oncologists. I'll look up and see what Anthony D'Amico's specialty is, and because I see him on a Dana-Farber radiation oncology list here, but I'm not sure he is.
Okay, I appreciate that.
Yeah.
Okay. Well, like I said, keep us updated and we'll see what we can do for you. We made it through. Sherelle, I know you had something that you wanted to share.
Yeah, thanks, Stuart. I'll be very quick. Just a good note, a good news story out of here in Alabama, where I am. I read an article last week that in our upcoming state legislative session next year, there will be a bill introduced to require prostate screenings for high-risk men to be fully covered by insurance without deductibles, co-payments, or other cost-sharing requirements. And it specifically mentioned DRE and PSA tests to be covered. And the bill would cover all men over 50 and men over 40 at high risk of prostate cancer. And the bill defines high risk as Black men and men who have a father, brother, or son to whom any of the following apply. 1, received a diagnosis of prostate cancer. 2, developed prostate cancer. 3, death caused by prostate cancer. 4, received a diagnosis of a cancer that is known to be associated with a higher risk of prostate cancer. And then 5, carries a genetic marker known to be associated with an increased risk of prostate cancer. And if the bill passes here in Alabama, we will join 9 other states that have passed legislation to eliminate or reduce cost sharing requirements for prostate cancer screenings. So I will keep a track on this and report back to y'all next year if this passes. And the American Cancer Society, Cancer Action Network, and Zero have endorsed the legislation. So that's some good news coming out of Alabama. And I will track this and hopefully I'll be able to report next year that the bill passed. That's all that I have, Stuart. Thank you for your time.
Thank you, Sherelle. That's really interesting and very encouraging that you got a state taking proactive measure like that. So keep us updated. Anybody else have anything for this evening? Okay, then we will be back in 2 weeks and we look forward to seeing you then. I see. Caller 3 is that.
Good night, everyone.
Bye-bye. Thank you, Sherelle. Greg, take care.
Are you just finishing up, Stuart? I just got back in the car. Hello. Well, I'm sorry. I missed. What I heard, you did great, man.
Thank you.
I'm coming back from Mason's memorial, so I had to stop off to do some shopping on the way back. But who was there to help you? I heard Dr. John. Who else was there?
Just John.
Oh, just John. Oh, we should stop the recording.
Oh, sorry.